Behind the veil, surgical management of a dense persistent pupillary membrane. Persistent pupillary membranes are common. However, extensive dense PPM covering the entire pupillary area are rare. Our patient is a 35-year-old female who came to us with diminution of vision in both eyes since childhood. Her uncorrected visual acuity was found to be 660 in both eyes, not improving with pinhole, and an ultrasound B scan of both eyes was found to be normal. On examination, she was found to have a dense membrane similar to the iris tissue, covering the entire visual axis and continuous with the collarette, suggestive of a dense persistent pupillary membrane, and this is what it looked like post-dilatation. Gonioscopy revealed open angles with no abnormal findings in both eyes. There were no syndromic associations identified with this case. Anterior segment OCT revealed a membrane in the pupillary area in both eyes. However, due to significant backshadowing, details of the underlying structures could not be visualized. While an ultrasound biomicroscopy would have provided better insight, it could not be performed in this case. The patient was planned for bilateral surgical membranectomy under topical anesthesia with a guarded visual prognosis. The procedure was performed using a bimanual clear corneal technique without the need for sutures. The following segment presents the surgical procedure. So first side ports are created and intracameral phenocaine is injected. OVD is placed over the corneal surface to improve visibility and then injected into the anterior chamber, but mainly between the iris tissue and the crystalline lens to create space and prevent damage to this lens. Then, with the help of a 23-gauge scissors, all the attachments of the PPM are cut slowly, taking care not to damage the underlying crystalline lens. In a similar fashion, all the attachments of the PPM are cut bit by bit, and finally, the remnants of the membrane are pulled to one side and the last and final attachments of the PPM are cut. The OVD is washed out and pilocarpine is injected into the anterior chamber to constrict the pupil. Pilocarpine wash is done and the side ports are hydrated and the case is closed. In the immediate post-operative period, she was started on eye drop moxifloxacin plus dexamethasone 4 times a day, which was then gradually tapered weekly over 1 month. The other eye also underwent the same procedure. There were no intraoperative complications in either of the surgeries. At the end of 1 month post-operatively, it was seen that indeed underneath this veil there was a normal pupil and a crystalline lens, giving the patient a best corrected visual acuity of 618 in the right eye and 624 in the left eye. At the 6-month follow-up, the patient's visual acuity was maintained, the crystalline lens remained clear, the intraocular pressure was within normal limits, and the visual axis remained well centered. Similar surgical techniques have been described by Adel et al., Hewling et al., and Courtney et al. Our video contributes as a visual adjunct to the existing literature. While Bowie et al. Have reported the use of Nd:YAG laser for persistent pupillary membrane removal, this approach is not feasible in cases with thick, dense membranes such as the one presented here. While this case highlights a successful surgical approach, certain limitations must be acknowledged. First, preoperative ultrasound biomicroscopy could not be performed, which may have offered better characterization of the membrane's depth and relation to the lens. The follow-up duration presented is short, limiting insight to long-term outcomes. Histopathological analysis of the excised tissue was not conducted. In conclusion, in such cases of dense persistent pupillary membranes, surgical management is ideal, where 23-gauge scissors and forceps under copious ophthalmic viscosurgical devices serve as useful tools. Although this is a safe surgery, there are chances of iatrogenic cataract formation, which is why the surgeon needs to be precise and patient throughout the surgery. Since there is clearing up of the visual axis, the surgery is indeed rewarding. However, patient counseling regarding the loss of pinhole effect amblyopia, and the presence of a residual refractive error post-operatively is of utmost importance. Informed consent was obtained from the patient for both the procedure and the use of clinical images in this video.